Patient is a 4-year-old patient.
Okay.
Has been using amplification by hearing aid for more than 2 years. Immunized for pneumococcal, H influenza B and the meningococcal vaccine, the pneumococcal 13. And see, these patients require lot many workup, not only this medical workup, radiological workup, audiological workup, psychological workup, behavioral workup. So many things are required to be looked into when you plan a case for cochlear implant surgery. Coming to the radiology, what we need to see in radiology? Number one, is there anything which precludes cochlear implant surgery? What we need to see on radiology, that something which precludes cochlear implant surgery is not there, like the lumen of the cochlea and the presence of the cochlear nerve. These are two most important things to be seen on radiology, and that is best depicted by MRI. Another thing to see into radiology is the anatomy of the ear or the temporal bone where we are putting the implant, so that are there any anatomical situation which can complicate our surgery. Okay? Hello?
Yeah.
So on MRI, what we need to see is the lumen of the cochlea. The fluid-filled lumen of the cochlea is essential for the implant to go inside, and that is best depicted on a T2 weighted MRI. And here, can you focus here? Zoom kar do isko. Can you see the fluid-filled cochlea here?
Yeah.
Is it clear?
Yes, yes.
On the axial sections?
Yeah.
On coronal, and you see the nerve also here. That's not very clear in the axial because the sections are very, very coarse. So to see the nerve, the best view is sagittal section. Look at the sagittal section at the level of the intra-auditory canal. Can you see the 4 nerves?
Yeah, we can see.
And this is to ensure that your cochlear nerve is there. These are the two important things to be seen on MRI. Rest of the details you can take from CT scan, like what you need to see in a CT scan in a cochlear implant patient, the size of the mastoid cavity, the dura. If it is a low dura, anterior sigmoid, it can complicate and you may have to change to your approach. Second thing is the facial nerve. If there is any anomaly of the facial nerve which can complicate your surgery. Third is the jugular bulb. The jugular bulb should be seen if it is coming high. The high jugular bulb which can complicate comes into the picture when it goes above the level of the posterior semicircular canal. So that you can see here, the jugular bulb is here, low down. It can sometime cover even the round window or even go high up, and then you may have to change your approach. Fourth is the dimension of the intra-auditory meatus and the aqueduct. Where is the other scan? See the dimension of the intra-auditory meatus, can you see?
Yes.
And the aqueduct, CT, axial. That you need to see if it is dilated. Then the cochlear turns, you can have a good view of the cochlear turns here. See all the 3 turns of the cochlea in this picture. Can you see?
Yes, yes.
And see how the intra-auditory meatus is going to the cochlea here. See, this is the end of the intra-auditory meatus here.
Yes.
And this is the cochlear base. This cochlear base defect can lead to a CSF gusher. And that abnormality in terms of cochlear malformation is designated as IP3, incomplete partition 3, which has a high probability of giving a CSF gusher. Okay?
Okay.
Now, from the intra-auditory canal size, if the intra-auditory canal size, one can assume that all 4 nerves should be normal. Studies done in patient having normal intra-auditory canal size but the cochlear nerve deficiency. So don't rely on the size of the cochlear intra-auditory canal size for the presence of cochlear nerve.
Okay.
You have to see cochlear nerve per se on MRI. Then another thing is the partitions of the cochlea, you can see all the 3 turns of the cochlea with good partition. I don't have a, give me another CT. Yeah. नहीं एक और था ना, नहीं था ना, एक और था. Can you see the cochlear partitions?
Yes.
So what happens, what we need to rule out is any cochlear malformation in that particular patient. See, cochlear malformation happen to occur if during the embryo, during the growth of the cochlea, if the growth is arrested at that particular time. The cochlea starts growing at the 3rd week of gestation and becomes adult size at 25th week. So, if the growth of the cochlea is arrested, the development arrested at the 3rd week, there will be no labyrinth, no cochlea, and will be a Michel deformity, and there is no question of cochlear implant surgery in that situation. 4th week, when the cochlea and vestibule differentiate, and if the growth is arrested, then what you can have, because there is no differentiation of the structure in the cochlea, and then you can have a common cavity deformity. Okay? 4th to 5th week is the time when the cochlea doesn't differentiate into the all the turns, and if the growth is arrested there, then the patient will have ultimately a common cavity deformity. Then as you go on, the cochlea starts developing. At the time when the growth is arrested, according to the malformation will come in. So all these come under cochlear hypoplasia. Intermittent partition has been described very clearly, separately. IP1 is when there is no partition in the cochlea is a single cavity. Common cavity when cochlea and vestibule are a common cavity.
Okay.
No differentiation between cochlea and vestibule. Then in the 5th week, that happens in the 4th week, common cavity. In the 5th week, when the cochlea doesn't have internal architecture, then it's a common cavity that is known as IP1 deformity. In the 6th week, there are variety of cochlear hypoplasias like a small cochlea, the very small size cochlea, small size vestibule, the variety of things can you see. In the 7th week is the IP2 deformity which takes place when the growth is arrested in the 7th week. In that, there is a normal basal turn, the apical and middle turn fuse to form a common cavity, along with a dilated vestibule and enlarged cochlear aqueduct, and that is known as Mondini's deformity or IP2. IP3 is when the cochlear base is defective. In the base of the cochlea is a cribriform region which separates from the intra-auditory meatus. If that is defective, the intra-auditory meatus, the CSF is in continuity with the cochlea, and if you do a cochleostomy, it manifests as a gusher. So all these things you need to see and evaluate on the CT scan and MRI to rule out any malformation. If there is any malformation, you have to handle in that particular way. The issues come with the implant insertion. You need different variety of electrodes, sometimes the short electrode, double array, and many things which I am not going to discuss over here. We'll discuss intraoperatively when we get time. And the complications in the post-operative period, intraoperative and post-operative period, like CSF gusher, you have to deal with the tight packing around the cochleostomy and prevent the meningitis with good antibiotics and all those issues. So all those complications are associated in malformed cochleas. Now the approach to this surgery, ours is a conventional posterior tympanotomy approach, the widely accepted approach. Dr. Dubey has recently spoken on this thing, the Varia approach, that is another approach. Then in difficult situations, now the other difficulties occur in the meningitis situation when the cochlear, the labyrinthine ossificant take place and the cochlear lumen is compromised with the fibrous tissue and the bone ultimately, and that complicates the cochlear implant surgery. So there are many other approaches, and the approach every cochlear implant surgeon should know is the subtotal petrosectomy with blind sac closure approach. That is a very important approach required in many situations, in the difficult situations, like in ossificans, labyrinthine ossificans. You need good exposure to drill out the cochlea at various levels. You can't do with the posterior tympanotomy. In the situation of high likelihood of CSF leak, you can deal with the CSF leak better if you have a subtotal petrosectomy, remove all middle ear tissues, close the Eustachian tube, remove all epithelium out and do a cul-de-sac closure, and then close the CSF more efficiently with the blind sac, with the cavity closer with a muscle or a fat. So there are many approaches, and any cochlear implant surgeon should be well versed with all these approaches.
Satish, please tell us about MRI also, how you know whether it is right side, left side. And
Okay, right side, left side is always mentioned. Deepak, on MRI, इसका axial और है क्या अच्छा? On MRI, like CT scan, you can start seeing from above, below. You will see in the internal auditory meatus. What we need to see on MRI here is the nervous architecture of the nerves in the internal auditory meatus, the cochlea, semicircular canal, and all those things which are part of the labyrinth. See, out of all malformation of the labyrinth, the commonest malformation is the lateral semicircular canal malformation. But it doesn't affect our cochlear implant surgery much. But it can affect the course of the facial nerve. So that is always something to be keep in mind. Yeah. Yes, this is a better MRI. Deepak,
yes, yes.
let's see. We are coming from above downwards. Okay?
Yes.
Here. Now see the both side vestibulocochlear nerves. Can you see?
Yes.
Both sides vestibulocochlear nerves. Now in the internal auditory meatus, the superior group of nerves are what? Anteriorly facial nerve, posteriorly superior vestibular nerve.
Yes.
And the inferior group of nerves are anteriorly cochlear nerve, posteriorly the inferior vestibular nerve.
Yes.
Okay?
Yes.
See, the turns of cochlea with the intensity of fluid in the T2 weighted MRI. Can you see? Can you see?
Yes, we are seeing if you can
I-
hold some pointed, means
Oh,
pointer
okay.
or needle, something like that, so it is easier.
What to see in MRI is the T2 weighted image which gives you a clear picture of the fluid in the cochlea. Can you see this?
Yes.
Can you see both sides?
Yes, yes.
And this is the cochlear nerve.
Okay.
Now see inferiorly, these are two nerves, the sections are too wide, jumping. So inferiorly this nerve going to the cochlea is the cochlear nerve, and on the other side, posteriorly, is the inferior vestibular nerve. As you go high up, you find the facial nerve. Now there is no cochlea in the view, and this is the facial nerve going on both sides. Can you see?
Yes.
And the superior vestibular nerve. This is semicircular canal. This is posterior semicircular canal at this level. This is vestibule. This is lateral canal. Can you see?
Yes, yes.
See the ring of the lateral canal and the
Yes.
vestibule. So on MRI, only two things which are most important from cochlear implant surgery is the nerves in the internal auditory meatus and the cavity in the cochlea. Fluid-filled cavity in the cochlea are the two major prerequisites for a cochlear implant surgery. On CT scan, as I mentioned, you need to see a lot of things which can complicate your anatomy and surgery, and the aqueducts and the
Dr.
intra auditory
Satish,
meatus dimensions.
Dr. Satish, hello.
Yeah. Hello?
Dr. Satish,
Yes, madam.
can you focus on that oblique sagittal view and tell us about all the cut sections of the nerve in internal auditory meatus?
Intra auditory meatus.
Yes.
See the
oblique
whatever
sagittal-
the MRI available to us.
You showed it before also. There is a cut.
Right side MRI film.
Yeah.
Film, right MRI, right side MRI film, complete film.
Complete film was there which was showing oblique
The
sagittal.
other
Another
film,
was
which is on your right side, in the view box.
In this
Yes,
one.
yes,
These
yes.
are sagittal sections.
Yes,
Yes.
you please tell us.
So on sagittal section, what you see the internal auditory meatus coming from medial to lateral on both sides. In the sagittal section, you get a cut section of the internal auditory meatus with all four nerves in place. Can you see?
Yes.
This is what you need to see on sagittal section. That gives the best picture of the internal auditory meatus and the architecture of the nerves. Can you see?
Yes.
Yes, we can.
This is so clear. All the four nerves with a good dimensions and the intra-auditory meatus with a good dimension.
If you have doubt whether the cochlear nerve is there or not in CT or MRI or in MRI,
Yeah.
how you confirm that?
Yeah, see, that's a very debatable issue. Number one thing, I make it very, very clear to you. Cochlear nerve is essential for the cochlear implant to work. We all know.
Yes.
Now, cochlear nerve absent can take place along with a malformation in the inner ear, or can be a solitary entity with a normal middle ear, normal inner ear structure. I mentioned in the beginning, the ultimate size of the intra-auditory meatus doesn't make any difference to the presence or absence of the cochlear nerve. It has nothing to do. Lot of series published, 50% patients having absent cochlear nerve, having normal intra-auditory dimensions. What is the narrow dimension of the intra-auditory meatus, which is the cutoff dimension is less than 3 millimeter. If the dimension of the intra-auditory meatus is less than 3 millimeter, the chances of cochlear nerve deficiency are there. Then you have to be careful. And then MRI will confirm. Sometimes in those situations, in the narrow intra-auditory meatus, even the MRI cannot clearly differentiate whether it is a cochlear nerve or not.
Yes.
So then you have to take the advantage, take into consideration the audiological and electrophysiological tests also. E-BARA is one test. What you do in E-BARA, you stimulate the promontory and record the signal at the level of the brainstem.
Yes.
If you get the E-BARA recording, that means the cochlear nerve is working. Got my point?
Yes. Yes.
Now sometimes the fibers of the cochlear nerve you don't see per se, but have intercommunication with the other nerves in the intra-auditory meatus. If there is absolutely absent cochlear nerve, definitely the cochlear implant cannot be done. In the cochlear nerve deficiency, still cochlear implant is the first answer to the patient, and if it doesn't work, then ABI is the final answer. Next situation. So this has to be handled in a very, very different way. The cochlear nerve presence or absence or a deficiency, and accordingly patient should be treated. But yes, in the internal auditory meatus, dimension is less than 3 millimeter. That warns you that the patient may have a cochlear nerve deficiency. Normal dimension doesn't have any role with the cochlear nerve dimensions. So I'll come back in a minute. I'm going for a wash up and then we'll start. और साबुन आमुन है क्या नहीं?
Meanwhile, okay. Meanwhile, Dr. Deepak Dalmia will show a video of the implant surgery. It will take hardly 3 minutes. Meanwhile, Dr. Satish Jain is going to wash.